Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. So today, unfortunately, the resident who was going to speak on male infertility is not there. So I thought, why not take this chance to have a class of residents on male infertility. And fortunately, just the other day, I got the final permission that it is our guidelines on male infertility, which we started working on last year, has finally been approved by the Indian Journal of Urology, is going to be published in the next issue of Indian Journal of Urology, the executive summary. And those guidelines are also there on the website of our Urological Society of India. So thank you once again. I welcome my residents, my faculty, and all the urologists who might have joined us today on YouTube and the Zoom link. So infertility, as we all know, is defined as the inability to conceive by a couple after 1 year of regular unprotected intercourse. And 15% of the couples do suffer from infertility. And male factor is contributory either solely or partly in half of these cases. The major concern here is that often we do not or neglect evaluation of the male partner. The reason is, one of them is that infertility is usually taken as a gynecologist subject. And with the mushrooming of the infertility centers around the country, this is being taken by mostly the gynecologists. And the urologists usually take less interest in evaluation of the male partner. But it is very important to evaluate the male partner. And why it is important? Number one reason is that infertility has a significant social impact in our society. I remember a quote from Kamb Ramayan, which says that no happiness is greater than the happiness of a woman who is declared barren in the society delivering a child. So infertility not only affects the person, the couple, his or her family, but it affects in a number of ways, psychologically, socially, in many other ways. And often the females are being stigmatized for infertility. So the male partner needs to be evaluated to save these females from the social stigma of infertility. It has also been seen that many of these patients present as infertility, and we find out that they have actually sexual dysfunction or they come with unconsummated marriages. So definitely all these patients can also be helped if you evaluate a male partner properly. There are some conditions where it is difficult or it precludes deposition of semen into the vagina because of the anatomical abnormalities of the penis, like Cody, proximal hypospadias, meatal stenosis or phimosis, all these which can preclude deposition of semen into the vagina, also come into light when you actually evaluate the male partner. Then there are various serious underlying conditions which you can diagnose when you actually evaluate the male partner. There are various hormonal conditions related to glands like pituitary, hypothalamus, and even the gonads. There are tumors of pituitary, hypothalamus, or even testicular tumors can present as infertility. So all these important serious clinical conditions can be diagnosed when you actually evaluate the male partner. And definitely you can manage this infertility in a more simplified manner by managing the treatable conditions that we will actually see during the discussion. So the main objective of evaluation of the male partner is to ascertain if the male partner is contributory solely or partly for the couple's infertility, to identify the potential correctable conditions which can be corrected and the infertility can be managed, to identify those irreversible conditions which are amenable to assisted reproductive techniques so that the patient can be managed accordingly, and to identify those irreversible conditions which cannot be managed by assisted reproductive techniques so that the patient can be counseled for donor insemination and adoption. And as I said, to identify those significant underlying medical conditions that can manifest as infertility. The various causes, as we know, can be divided into three parts: pre-testicular, testicular, and post-testicular causes. Pre-testicular causes, again, could be congenital, like Coleman syndrome and other various syndromes. Post and acquired could be due to various tumors involving the pituitary, infiltrative disorders, injuries, head injury, etc., all which can lead to various pituitary and hypothalamic causes. Then the testicular causes, again, could be congenital, like Klinefelter syndrome, and then could be acquired as postpartum sarcitis or testicular atrophy or even testicular torsion. And the post-testicular causes, again, could be congenital, like congenital absence of vas deferens. It could be ejaculatory duct obstruction, which could be acquired also. Then it could be various acquired causes like post-vasectomy, or even infective causes which cause obstruction at the epidermo-basal level. So as we go in any other case, history is very important in evaluating. The duration of infertility is again important, because longer the duration of infertility, lesser the out success of managing such couples. So we need to evaluate as early as possible as when they are diagnosed. Age of partners, as we know, is again important, because as the age advances, the ovarian reserve in female would be less, and the males also could suffer from other comorbid conditions which can reduce their impair their spermatogenesis. Then, if there is any history of previous fertility, previous evaluation or treatment, knowledge of the reproductive cycle is also again important, because we know there are people who are ignorant of the reproductive cycle. They are ignorant of even the kind of intercourses which is required for proper conception. Then the coital frequency and timing is again important, because nowadays, as both partners are working, they usually meet maybe not every day or few days in a month. So it is important when they do actual coitus and the timing, which will help them to conceive. And the use of contraceptives, lubricants, sexual dysfunction, whether the patient is suffering from erectile dysfunction, or even some of them could have unconsummated marriages. And the volume of the ejaculate is again very important. So ejaculatory dysfunction, we need to take in the history. In the medical history, again, there could be congenital anomalies, cryptorchidism, history of chemotherapy or radiation exposure, which can cause impaired spermatogenesis, chronic medical illnesses, chronic bronchitis, which can cause inspissated semen, that is Young's syndrome, or post-pubescent mumps, where there is a risk of 30% orchitis developing subfertility. And then when did the puberty start? And all these things are very important to know if they are suffering from hypogonadism. And then the history of testicular torsion, past surgeries, injuries, all these can impair the ejaculatory function or even the spermatogenesis. Then in the medical examination, we must find out if there is any abnormality, underlying pathology which can impair spermatogenesis. Even thyroid problems can result. Then gynecomastia, whether any discharge or tenderness, abdominal examination, because systemic illnesses can also cause this problem. So in the physical examination, it should be a focused physical examination on the various secondary sexual characters, which if are impaired or which are abnormal, could be found in hypogonadism. Then we need to focus on the penis, its size, whether there is a presence of hypospadias, chordae, phimosis, etc. Then we need to see the testicular size, the volume, the consistency, and if we can palpate any mass in the testis. Epididymis, whether this is flat or full, whether you can feel some nodularity or nodules, which could be in many of the conditions like filariasis or tuberculosis of the testicles. Then vas deferens, whether they are present or absent. If present, can you feel that any nodularity? Varicocele, again, is an important cause for male infertility, needs to be examined both in standing and supine position and need to be graded. Then digital rectal examination will help us to know if there is a midline cyst, any seminal vesicle abnormality, prostate size, consistency, and tenderness. So semen analysis remains probably the most important investigation to diagnose male infertility. And the semen should be collected with about 1 to 3 days of abstinence. If the patient fails to ejaculate or give the semen, then the other options are like coitus interruptus, where they can collect the semen actually during sexual activity. They can collect in condoms with are lined by non-spermicidal layer. Then if these fail, then we can also get the semen ejaculated by vibrators. So vibrator is a very handy tool which can help us in these patients to induce ejaculation. So the semen should ideally be examined within 1 hour of the ejaculation, and it should be kept at the room temperature. And the parameters, if abnormal, found abnormal, they should be repeated at least twice at the interval of 2 weeks. So semen analysis, as we know, and the different seminal parameters are usually considered as to predict the fertility potential. But often we see that even if the semen parameters are normal, like in 1/3 of cases, even with normal semen parameters, the couple may be infertile due to the male reason, even if the female is investigated and perfectly normal. And we also find that in 10 to 15% cases, even with abnormal semen parameters, the couple is fertile. So actually, the semen analysis will not actually tell you that the couple is fertile or infertile. It can only give a suggestion. In fact, in 1951, when John McLeod published his study, when he examined 1,000 fertile and 800 infertile men for infertility with the different semen parameters like count, motility, and morphology, he found that 1/3 of these couples or men were infertile, were found in the range of count 1 to 20 million. So that was his inference only. But unfortunately, those values were considered as threshold values by WHO later, and they were created as reference values. And so the 20 million count was considered as something like below it, the person is infertile, above it is fertile, which is actually not true. And the WHO comes out with different manuals, and the There was a WHO fifth manual which came in 2010, where they made these parameters, like the volume should be at least more than 1.5, count more than 15 million, motility should be more than 40%, the morphology by Kruger's criteria must be more than 4%, and the leukocyte density should be less than 1 million per ml. And they also proposed a new report template of reference ranges. That is 5%, that is 5th percentile. So that means that in this particular reference range of 5th percentile, 5% of the men would be infertile. And in 50% of the men would be rather, 5% of men would be fertile. And here 50% percentile means the 50% would be fertile. And 95%, that is 95% of the men would be fertile. So in fact, we need, whenever we do the kind of semen analysis and make an inference out of it, we need to take care of these reference ranges. Nimeshji.
Yes, sir, muted.
Please take care of this disturbance, right? Somebody is probably, yes, please. Yeah. So, so whenever we do a semen inference of a semen analysis report, we need to take care of these reference ranges. And then recently, WHO has come with the 6th manual, which actually suggests that the semen analysis report actually doesn't categorize a person as an infertile or a fertile male. It only suggests that this person should be, how this person should be treated. Like they have now replaced these reference ranges by these values, where they consider this value as a normal, and then the borderline value, and then the pathological values. So it actually says that with a particular semen analysis report, we can only say that how this patient should be treated or evaluated. It doesn't say that the patient is fertile or infertile. So these are the various terminologies that we usually use when we get a semen analysis report. If it is normal, it is normozoospermia. If the sperm concentration is less, it is oligozoospermia. If the motility is poor, it is asthenospermia. If the morphology is poor, it is teratospermia. If all the parameters are at fault, then it is oligoasthenoteratospermia. If there is no sperm in the ejaculate, it is azoospermia. If there is no ejaculate, it is aspermia. So what do we see in the semen analysis? We see the physical characteristics of the ejaculate, like the viscosity, liquefaction, the pH values, etc. Then we see the count. Then we see the motility and the progressive and non-progressive motility. Then the sperm morphology, then the vitality, leukocyte count, and sometimes additional tests like semen fructose estimation. It is very important that these tests are done in standardized labs. That is, they have a standardization, both pre-analytical, analytical, and post-analytical, to give a proper optimum semen report. And the quality control should be certified and validated. And we need to take this WHO manual as the criteria for actually giving these results. As I said, it is not always true that the semen analysis will tell you the actual problem. And so we need to take a proper history, physical examination, and there are certain sperm function tests which can help us to know what is going wrong in this particular patient or infertile couple. So we know there almost 1/3 of these patients have unexplained and idiopathic infertility. And here, probably the sperm function tests can identify the deficiency by assessing the DNA fragmentation. and the oxidative stress and the sperm antibodies and genetic testings. All these can help us to know what is the exact cause in the particular male partner. So after semen analysis, what we need to do? Hormonal assay, should it be done in every case? No. So if the count is more than 10 million, it should not be done. If it is less than 10 million, then we may start with doing a serum testosterone level and serum FSH level. If the patient has hypoandrogenization or erectile dysfunction or hypogonadism, then we need to know also the LH and the prolactin values and also the TE ratio, because this is testosterone estradiol ratio, which if it is less than 10 will probably in that case aromatase inhibitors will help to improve the count and motility. So if the patient is suffering from hypogonadotrophic hypogonadism, again, the imaging study, MRI of the pituitary and hypothalamus would help us to diagnose the conditions. And sometimes this GnRH and SCG stimulation test will help us to know whether this is hypothalamic or pituitary cause. Genetic studies are important. Karyotyping, particularly Klinefelter syndrome, we know, XSY. Then Y chromosome microdeletions are very important causative factor in many of these patients with oligoasthenoteratospermia, where we cannot find other cause. Then CFTR mutant gene is important in cases of congenital bilateral absence of vas deferens. Now, in the recent WHO manual, they have also put a little stress on, as I said, on DNA fragmentation index, which may come as a routine test in near future. Similarly, reactive oxygen species estimation are also becoming more and more important. And though at present, the indications are not clear and we do not know whether this is cause or effect in infertility, and they are not routinely available. Genitourinary infection, which we call MAGI, that is male accessory gland infection, can also be the cause of infertility in 10 to 15% of patients. And for this, we need to take a proper history, examine the patient, if necessary, do a urine analysis, urine culture, or a urethral swab culture, or a prostate secretion culture, and sometimes even the semen culture. And if you suspect tuberculosis, then you need to do AFB smear and culture. So leukocytospermia is usually how they present, and which is an indicator not only of infection, but also inflammation of the male sexual gland. So sometimes there may not be obvious infection, but it could be just an inflammation of these glands, which can cause leukocytospermia and can result in this impaired spermatogenesis. So if the count is more than 1 million leukocytes, then we consider it as probably evidence of infection. A positive correlation between this leukocytospermia and the sperm deformity index scores, acrosomal damage, defects, and tail deformities have been found in various studies. So besides this leukocytospermia, which can be produced due to the infection or inflammation, it can also result from some environmental factors like smoking, chronic smoking, alcohol, drug abuse, etc. And even prolonged abstinence and certain sexual practices like anal sex can also result in leukocytospermia. So, but again, it is very important to differentiate these leukocytes from the immature germ cells, which usually look like those round cells, which can be confused. So it is important to do immunohistochemical staining, which is the gold standard. And sometimes this peroxidase staining will help us to diagnose leukocytospermia. Is semen culture required in every case if they present with leukocytospermia? No. The reason is that many of these infections, which are not by usual bacteria, they are by bacteria which we usually do not culture in the usual method. So that is like ureaplasma, chlamydia, all these infections, which are the main cause for many of these infections, are not cultured. So they will not come positive, and almost 80% of cases will come as negative, even if they have infection and inflammation of these glands. Similarly, many of these infections would be because of the commensals which are present in the normal urethra. So you'll get a combination of organisms which are actually growing because of the normal commensals, and they are not actual infections. So culture can be done only if you think it is clinically relevant and to find out the organism and the sensitivity to a particular antibiotic. Otherwise, empirically, we usually treat these patients with antibiotics which are sensitive to these various chlamydial and ureaplasma infections, which is usually azithromycin or doxycycline, which we give for 2 to 3 weeks or even 4 weeks. So studies have also shown that giving cyclooxygenase inhibitors, antihistaminics, antioxidants can also help in reducing this leukocytospermia, and even frequent ejaculations can help to reduce leukocytospermia. So frequent ejaculation is given as a kind of a treatment in many of these patients to reduce this leukocytospermia. Antisperm antibodies could be the reason in 10% of cases, and the various risk factors like vasectomy, torsion, trauma, infection, all this can cause increase in antisperm antibodies. But again, it is very important that antisperm antibodies can be found normally in, so doing these indirect assay in the form of ELISA or else, this would not help in most of these patients. So the actual test should be the direct assay in the form of immunobead test or mixed agglutination reaction assay, which is often not found in almost any lab in our country. So the direct assays, as I said, could be immunobead test or the mixed agglutination reaction assay. And the indirect assays are only important in the form of ELISA or when you need to do a quantitative assay. So if once we know that this is positive, the direct assay is positive, then you need to quantify them, how much is the quantity of these antibodies, then this ELISA test may be useful. And some of these patients can be treated, they have studies which shows that steroids, either in cyclical or intermediate or even long-term therapies might help in many of these patients. And often these are not indicated routinely, and we usually treat these patients by sperm washing and IUI or even ICSI. So viability assay can again be done. There are many patients you will find that they have very, very poor motility, less than 10%, which is called severe asthenospermia. And sometimes the motility could be even totally immotile sperms, which is called necrospermia. And this can be diagnosed by various tests like dye test and hypoosmotic swelling test. And many of these patients who have totally immotile sperms could be due to ultrastructural abnormality, which is absence of dynein arm, which can be diagnosed by seeing these sperms under microscope. So the various sperm function tests, as I said, postcoital tests actually can help us to know these problems which are due to the sperm functions. And then, as I said, DNA fragmentation index and reactive oxygen species are coming up in a big way to know the problems with this semen function, sperm function. The various imaging studies that we need to do is a transrectal ultrasound when we suspect a case of ejaculatory duct obstruction. That's the only indication. For varicose, usually do not do a scrotal ultrasound, only done in very equivocal cases where you can actually cannot palpate, like an obese patient or post-surgery on the scrotum. Pituitary or hypothalamus imaging could be done with MRI, particularly in case of hypogonadotrophic hypogonadism, which could be both congenital and acquired. Testicular biopsy, the indications have gone down because many of these patients do not require a testicular biopsy, as we will discuss. And only it is done for equivocal cases of azoospermia. That's it. And therapeutic testicular mapping biopsy, it can be done for sperm retrieval in these azoospermic men. And it is never these biopsies are sent in formalin. It has to be sent in Boyne's fluid, as we all know. So this sperm retrieval is again a very important part of the andrology, which we urologists should all know. And the various techniques to retrieve sperms from testis and epidermis include PISA, that is percutaneous epidermal sperm aspiration. It could be MESA, which is microsurgical epidermal sperm aspiration, testicular biopsy, percutaneous or open testicular final aspiration. And there are other techniques which we often do is single seminiferous tubule technique, SST technique, or NAB technique, the needle aspiration biopsy from different sites of the testis could be the way to do these biopsies. And usually we need to do it on both the sides. And the microtessi, that is the microdissection testicular sperm extraction, is probably the gold standard and probably the best way to retrieve these sperms in a case of non-obstructive azoospermia. So this is the way how they do PISA, and this is MESA, microsurgical epidermal sperm aspiration. This is needle aspiration biopsy. This is with a cut, and this is the microsurgical testicular biopsy. When I was there in New York Presbyterian Hospital in the year 2000, when this Peter Schlegel, he was a consultant there who actually started this microsurgical, and I used to see often these Peter Schlegel doing this microtessi, when he used to devote hours together searching for those, he used to just open up, bisect the testis and try to see those fluffy seminiferous tubules, which would look a little juicy under the microscope. And those particular seminiferous tubules will be just collected, and then he will mince it under the cover slip and on a slide and just see if there are presence of sperms. And that actually helps to improve retrieving a sperm. So whenever such a patient comes, we can classify these patients by the inference of semen analysis report. Many of these patients will not be able to ejaculate at all, that is aspermia. And the causes could be either retrograde ejaculation, which should be ruled out. It could be anejaculation, which could be anorgasmic, that is psychogenic. It could be orgasmic, which could be due to organic reasons like obstructive. It could be due to drug induced. It could be due to surgery, diabetes, neurogenic. All these causes we need to keep in mind if it comes with anejaculation. So if it is a situational anejaculation, many of the patients will not be able to give semen when they are demanded, which is usually often done in patients at ART centers when they are asked to give the semen. So in these patients, often home collection can be advised, or even a vibrator can be very handy for inducing ejaculation. And those patients who are not responding to any of these electroejaculation with Seeger's electroejaculator could be helpful. So anorgasmic, if the patient has psychogenic problem, then he needs a psychotherapy, and the vibrator again can be very handy in these patients. And those who are orgasmic anejaculation, here there are various drugs like sympathomimetics and hormones, vibrators, all these can help. And the last option would be again ART or a sperm retrieval with PISA. So if the semen analysis shows oligoasthenoteratospermia, then the various causes could be infection, varicocele, systemic illness, prolonged abstinence, drugs, cryptorchidism, antisperm, antibodies, etc. And many of them could be idiopathic also. Sometimes even scrotal fungal dermatitis can cause oligoasthenoteratospermia. So do examine the scrotum also before treating these patients. And filarial orchitis, as I said, could be the Maggie, could be one of the cause which needs to be treated. And then definitely hypogonadotrophic hypogonadism is the very important medical conditions which can actually reverse this azoospermia, and the patient can actually help in conception. Varicocele, as we know, is the commonest surgical cause for such a semen report. And this is found in almost 90% of these are actually left-sided. And even in normal population, 15% can have varicocele. So we need to actually differentiate. And the treatment is needed only in patients who have clinically palpable varicocele in an infertile couple with a fertile female partner and with abnormal semen peritonitis. Obviously, there are certain exceptions where we can do this surgery, even if these criteria are not met. Then the various approaches, as we all know, could be retroperitoneal, inguinal, subinguinal, and but the microsurgical approach, which is done with the subinguinal incision, is probably the best approach. There are other approaches like laparoscopic or even percutaneous embolization or antegrade scrotal sclerotherapy, which can help. So often when I was there, Mark Goldstein used to always get the testis out, and he would also ligate the gubernaculum when he is operating on these cases of varicocele. And definitely the gubernacle veins along with the external spermatic perforatus need to be ligated to reduce the recurrence in these patients. So we all know about this microsurgical varicocelectomy, where the testes are often, we need to identify, separate them, and then ligate all those veins. So the various techniques, the results are best with microsurgical subinguinal varicocelectomy. And again, there are various drugs which can impair spermatogenesis. So it is important in the history to know about the drugs which the patient is taking, which can impair spermatogenesis. There are, again, as I said, it could be idiopathic or unexplained infertility, where we need to give some empirical therapy in these patients, which will include lifestyle changes, avoidance of heat exposure, toxin exposure, and stress, avoidance of smoking, and then certain empirical therapies in the form of anti-estrogens like clomiphene, tamoxifen, etc., antioxidants, and micronutrients, which can help to improve the semen parameters. And it is important that we know that such therapy should be followed at least for 3 months, because at least for 1 or 2 to 3 months for one cycle of spermatogenesis to know the result of such a treatment. And but it need not be continued forever, indefinitely, because if the patients are not responding in 1 or 2 spermatogenic cycles, they probably would not respond. So stop the treatment and go ahead with the probably ART in these patients. So we know ART, we should not, as soon as possible, because the fertility potential becomes poorer as the age advances. But again, mind it that we should not rush if the trying time is very short in every patient, as often is done in many of the fertility centers. And usually, if the sperm count is more than 5 to 10 million, we go for artificial insemination. Or if it is less than 5 million or less than 1 million, we will go for IVF-ICSI. So if the patient has azoospermia, and that should be always diagnosed when the pellet of the semen after centrifugation is examined and found that there is no sperm, then also only the patient should be labeled as azoospermia. And this could be, as we all know, obstructive, non-obstructive, and obstructive could be at the levels of epididymis, vas, or ejaculatory duct. And if the patient has azoospermia with a normal volume, when the fructose is positive, and the clinical examination is, we do the clinical examination and a serum FSH estimation. And If it is a normal FSH, normal volume, and the epidermis is found turgid, then probably it's a clear-cut case of obstructive azoospermia, where we did not do a testicular biopsy and straight away go for exploration, check the vasal patency, and go ahead with vasoepidermal anastomosis. And so this is the way we usually do this microsurgical vasoepidermal anastomosis by intussusception technique. If there is vasal obstruction, we will do a vasovasal anastomosis. And this is again the Mark Goldstein's technique of a multiple dot technique, where he puts dot on both the sides and then anastomoses the vas to vas in 3 layers. So if there is azoospermia, but there is low volume, pH is low, fructose is negative, then we need to rule out retrograde ejaculation, examine the vas. If there is not present, is a clear-cut case of congenital absence of vas difference, and then we need to counsel these patients. If the patient wants to get this ART, then we need to do the genetic studies in the form of these mutants in both the couple partners and CFTR gene mutations. And if they do not want, then we need to go ahead with donor insemination or adoption. If the vas is palpable and we do a transrectal ultrasound, there is a ejaculatory duct obstruction and is a cystic lesion, we need to go ahead with doing transurethral dissection of the ejaculatory duct. And if on trust you find that it is a fibrous kind of ejaculatory duct obstruction, then again, it is a non-operable case and we need to go ahead with ART. So if the patient has a low volume testis, very high serum FSH, which is usually more than twice the normal, then again, biopsy is not required. We discuss the various options. If the patient is not wanting ART, then discuss with him about donor insemination adoption. If they want or consider ICSI, then we need to do genetic studies in these patients and then do a trial TESI or SST technique of testicular mapping and cryopreserving these sperms. And that can be used for a further IVF ICSI, or fresh sperms can be retrieved at the time when the wife is stimulated. So again, if you do not find anything abnormal, but again, still the patient is infertile, then the various abnormalities could be either with the partner, that is gynecological abnormality. It could be immunologic causes. It could be even abnormal coital habits. It could be defective sperm functions, and there are various other unexplained causes. So to conclude, semen analysis, though considered as probably the cornerstone diagnosis, it actually doesn't tell you whether the person is fertile or infertile. So we need to have, and it is high time to bring robust and cost-effective, clinically useful sperm function tests to replace at least partially the shortcomings of the routine semen analysis. And now it is our responsibility to diagnose these existing conditions that may compromise now or in future the fertility potential of our patients, to identify the potentially life-threatening conditions that can cause male infertility, to treat and reverse these conditions, and also help these patients by counseling them about lifestyle habits, subclinical infections, hormonal disorders, and treating the clinical varicocele. As we all know, maybe a couple of decades ago, it was unimaginable to imagine even that a single sperm could be injected under the microscope into the ovum and will help us to treat these patients, which is called IVF ICSI, intracytoplasmic sperm injection. In the near future also, we do not know what is holding in the future. It could be very bright, and with the various research being going on with stem cell therapy, which can actually induce development of germ cells in the testis with various cloning techniques, then even in vitro development of in vitro spermatogenesis, and then even transplant of haploid germ cells into the testis, and even testicular transplantation, which may be a possibility in the near future. And definitely the future is very bright in the management of male infertility. So thank you. Thank you once again for your patient hearing. I'm ready to take any questions. What's the time now? 9:40. So we can devote maybe 5-10 minutes for any question or query that can have from our faculty, residents, or anybody who might have joined us today. So you can put it in the chat box if there is any question. From our residents in the meantime, do you need any kind of clarification? Yes, Dr. RD. Yes, please.
As you said already, 30% of the patients are having normal, the semen analysis
Could be unexplained, yes.
Borderline.
Yeah.
So in these cases, we have to go for advanced investigation or directly we should go for IUI?
Yes. So many of these patients, if they have normal semen parameters. So one is patients who have normal semen parameters and you are not able to find the cause also, right? And still they are infertile. In that case, yes, we need to know whether what semen parameters is actually, if they have oligoasthenoteratospermia, then we need to empirically treat these patients for 1 or 2 spermatogenic cycles by various lifestyle changes and antioxidants and even if necessary, hormonal preparations like clomiphene, tamoxifen. And if they are not responding, then we need to go ahead with assisted reproductive techniques. And if there are patients who have normal semen parameters, but still they are infertile. Again, those are unexplained or idiopathic, unexplained infertility. Here, in these patients, if the female has to be examined properly, we need to go into the proper history. There are some patients who actually will come with unconsummated marriages. They do not know the proper coital habit also, which is necessary to deposit semen into the vagina. And they may have some anatomical abnormalities also. So again, the history and examination is very important to rule out those conditions which can impair infertility in these patients. Once you have ruled out everything, the female partner is fertile, everything, then probably the only way to treat these patients would be assisted reproductive. So either by artificial insemination or IVF fixing in these patients. Anything? So I don't find anything in the chat box.
Few words
About? Yes.
infertility after testis, chemotherapy or radiotherapy.
Yes, a very important question asked by Dr. R.D. Sao about infertility in patients with testicular tumors, right? Testicular tumors. And so as we know that these are young patients and in the reproductive age group who suffer from testicular tumors, again, very important and mandatory for all urologists to preserve the semen. Cryopreservation is very important before we start these patients on any treatment, even radical inguinal orchidectomy. So these patients have to be, the semen need to be preserved before we start any treatment. And as we all know, even the chemotherapy or radiotherapy will impair the spermatogenesis in these patients. And we do not know whether this could be reversible also, maybe after 3-4 years. So to be on the safer side, we always need to keep the sperms and semen preserved in the semen bank. Again, many of these testicular tumors actually have impaired spermatogenesis because they have certain gonadal dysgenesis associated with testicular tumors. And even the testicular tumor is taking a toll on the spermatogenesis. So all these could result in impaired spermatogenesis to begin with. Again, so these patients have to be treated for infertility also. So I think it's important to have these patients. Yeah. Anybody? Yes.
Some patients with primary infertility with normal semen parameters. The general explanation they find like grade 3 varicocele. Does the treatment of varicocele is
Yes, that's a good question. If the patient has a normal semen parameters and a clinically palpable varicocele, should we treat the varicocele? That was the question. So as I said in my one of the slides, that there are exceptions where they do not meet those criteria of a fertile female, infertile couple, and clinically palpable varicocele for doing a varicocelectomy. So patients who have a clinical varicocele, particularly suppose in adolescents, in the age group of adult, you pick up some patients with testicular pain on the left side, which we often do in OPD. And if you find that on examination, the testicular volume is less on the left side, ipsilateral side with on the left side. And if you monitor these patients, then if the testicular volume is on the decreasing side, then definitely you can counsel these patients, saying that you may have a chance that later you may develop subfertility due to impaired spermatogenesis, and varicocelectomy can be done in such cases. So decreasing volume of the testis on that side is one of the indications. And if suppose many of these patients, on monitoring these patients may have reduced semen parameters. Right. So once they have a reducing semen parameters, even if they are not married, if the couple is not infertile, still diagnosed, you can go ahead with doing a varicocelectomy in these patients. Yes, but after proper counseling. So again, I would request you to go into the male infertility guidelines that we have done. There was a committee under the chairmanship of myself with 8 members, where we developed these male infertility guidelines for Urological Society of India. These are national guidelines, and these are public. These are already there on the website of Urological Society of India, and we are soon going to publish the executive summary of these guidelines in the Indian Journal of Urology. So I would seek suggestions and any ideas or any clarification you need in these guidelines. Those are most welcome. So thank you once again. Thank you, my residents, faculty members, and everybody who might have joined us today. Thank you. Thank you, Nimeshji, for supporting us and helping us. Thank you.
Sir,
So
my pleasure.
have a good day. Thank you. Have a good day.